following the study most likely needed on his diagnosis is audiometry, EEG, pH probe, hip ultrasound, or fundoscopic exam. So what are you guys thinking with this? So one, this is one of those questions where you got to figure out what he has first, and then based on knowing what that is, then there's some database questions of what you would likely need that's not directly related or for the diagnosis as much as the correlation. So what does this patient have?
Torticollis.
Good. So does anyone know what is associated with torticollis that you would have to evaluate for?
I mean, I would guess hip ultrasound potentially.
And for what reason?
Because this is an ortho lecture.
Yeah. But what would be the diagnosis, I guess, because that's where they could get you a different way, right? Like, so torticollis is, and that's again thinking through the congenital component of it. So the torticollis came from what, and therefore what would be wrong with his hip?
Would it be like oligohydramnios of some sort or something?
Well, that would be, yeah, bigger picture could be, but yeah. So and then what goes along with oleohydramnios or that tight packing? The most common hip problem that you would look for in a child too.
Genital hip dysplasia or breach or something?
Right. Well, breach would be, again, that would put him into that category to have developmental dysplasia of the hip. And then, like you were saying, this is where you coordinate and correlate the torticollis component of things. So this is definitely torticollis, which most of the time is the muscular fibrous component. So that's where just something that's really tight. Most of the time, actually, on the right side, for some reason, there's a lot of weird congenital things where I guess just babies like to go one way. So 75% of the time, it's actually on the right. And then 1/5 of these have issues with their hips. So that's where just always thinking about the hip ultrasound again, trying to connect all those dots. And then there are other orthopedic type issues that you can see with types that you see, and then like kind of misdiagnoses where this could be something not just straightforward. So always kind of thinking of the zebras here, and that goes along with birth trauma, clavicle fracture where he's splinting because of the pain, tumors in the brain where it's causing him to have issues. There's the Klippel-Feil syndrome where you get the congenital malformation that's looking at like the short neck, the scapula being off, and then obviously other things like where his eyes are off, so he wants to turn his head so he can see better. Reflux is something that obviously if it's random, and then there's a kind of paroxysmal where it's into that migraine variant. So every once in a while they kind of do it. Then this one is you're in the nursery and you see a newborn with multiple abnormalities. The baby was born at 37 weeks to the 34-year-old, delivered by C-section, was a breech presentation. Birth records reveal that there was short 2-vessel umbilical cord. On physical exam, the patient appears pink, cries vigorously, and manipulates. When you manipulate the joints, and then you see these flexion contractures of the elbow, wrists, hips, and knees. So again, this is where you got to think of what this baby has. And then now what they're asking you, of the following, the primary cause of this patient's contractures is chromosome abnormality, cephalopathy, fetal akinesia, muscular dystrophy, or a neuromuscular disease. So does anyone know what this patient has? So it's a fancy name. And if you don't, and I guess that's where, again, knowing what it is, then you can connect the dots of what causes that primarily. But does anyone have a guess what the primary cause of this infant's contractures is? Or again, what you're thinking might be some thoughts that you're trying to think through.
With multiple problems, possibly like a chromosomal thing.
Yeah, I mean, that's obviously the first thing that picks into your head. So then you would just want to figure out what are these multiple problems. So again, someone might say, oh, they see all these little random things. So that's where you got to know your database on two vessel cords and like, what does that really mean? Trying to connect the dots, obviously getting more information. And then that's what's hard about test questions sometimes is they're not going to give you more information. In real life, you would get more. So then you got to go with the most likely cause and then the primary cause. And then again, what is actually causing that? Has anyone thought of what condition this patient has? It's actually a very common test question. I actually just ran into Stalwart talking to Liz about it because it's something that they always like to ask about. So this patient has arthrogryposis. And then does anyone remember what causes that? So again, this is one of those fetal akinesia, so like tight packaging type problems. But this one is one of those that affects the joints. And so this little girl looks like a little ballerina, but she's actually has contractures all over. Otherwise, she's completely normal, no visceral abnormalities, really normal IQ. They just have the orthopedic contractures. So they'll arthrogryposis, multi-complex congenita, it's it. And you see it's 1 in 3,000. So it's not a, 1 in a million type thing. So these are little things that you would see. Sometimes they start trying to trick you into this category too of the amniotic band syndrome, where those are where the bands are tightening and causing issues on their fingers or joints too. So that would be where you get a wrap around and it's actually cutting off fingers. And again, this is contractures similar to the hip and torticollis component. So this is a 1-year-old that comes in for a slight curvature of the back that you notice and a small prominence on the left lower back. You end up getting an x-ray and you see this. And so does anyone know what you're worried about in this patient? One, what do you see on the x-ray? And then what would, again, knowing that the test question would list, again, a multiple choice question. But in real life, you don't always have that multiple choice question. So does anyone know what you would diagnose this patient with and then what you would subsequently need to order?
I don't know if it's I don't know the official name, but isn't it like a congenital wedged vertebrae?
Yeah, that's, I mean, a hemivertebrae type thing. So again, like what we talked with the torticollis in the neck. So this is, yeah, for some reason they didn't form that full vertebra. So it's a wedge shape. So therefore everything is curved because of that wedge shaped or a hemivertebra. So this is kind of a schematic of all the little things that can go wrong. So you see in this like second one is the hemivertebra. Wedge is, they think of a little bit more like it's full, but it's wedge shaped. And then there's like, you can get a bar or like a block of them too. So these are all possibilities. And then obviously this is then causing scoliosis, but then what would be like your next thought process after that? So obviously getting to see an orthopedic surgeon, and you can debate whether or not you ordered or refer to the orthopedic doc, pediatric orthopedic doc, obviously. And then, but what would be the test question of what would else need to be evaluated?
Would it be your pelvis?
So I mean, you could argue like multiple, looking at all the rest. So that's where obviously a good physical exam to make sure no other abnormalities are seen. But I would say like the rest of her exam is normal. So then it would be specifically then narrowed down to the spine, right? Like you're saying, okay, there's an abnormality in the spine. And this is where you start trying to think of, okay, once you start getting these congenital things of the spine, certainly they can have other bony abnormalities, but that's where you start worrying about more detail of investigating it more. I wanted to just throw in the one slide about scoliosis again, because it's technically congenital, but we see it older. And this is the slide, just the basic information you would need to know on like adolescent scoliosis. So the more common one, but again, that's where they differentiate scoliosis from the adolescent standpoint to more the congenital juvenile type. So this patient, obviously being one, would have the congenital type versus this type that we see as the patient grows up, and then the twisting starts happening. And then now you're trying to look at skeletally immature versus mature. And then often on the test, they'll ask you about the degrees where you just follow up and watch, or they'll even throw you off where they won't even give you like a full scoliosis. They'll just give you less than 10 degrees, and that's where you can just monitor it over time. But this being congenital scoliosis, there's some thoughts of this is where you start connecting the dots, and 10% have a cardiac abnormality, 25% have a GU abnormality, and then 40% have an intraspinal abnormality. So on the test question, if it had those choices, which is again hard because you probably want all of those, and so to say which would be the highest yielding, I guess, and this would be where an MRI of the spine to look for those intraspinal abnormalities. Lipomas, unusual things with the tethered cord and syrinx are the things that you would want to look for. Again, where obviously the orthopedic would be doing that, hopefully, but this is where also then you knowing that this kid has that, you would say, okay, well now if that kid comes back with any of these problems, well, his likelihood is high to have some of these other congenital abnormalities. This was just a study looking at MRI in kind of idiopathic less than 11, and they were just showing that a lot of these kids do have abnormalities. Once you start getting scoliosis so early on, then that's when you really start thinking about, okay, let's put it in a different category. And so it is indicated for routine less than 11-year-old that gets scoliosis to still consider the MRI, because again, the findings just really go up, where now seeing a neurosurgeon would also be part of the plan. And then just a reminder of what tethered cord is. Again, common in that little kids, and that's where you start getting that thickening, pulling at the spinal cord. They'll obviously when they get older, they can complain of back and buttock pain. This is where you start getting some neurological symptoms, and so tethered cord is always one of those you want to keep in the back of your mind, along with the sphingomyelin or the syrinx. And so most of the time those are up higher, but again, that's where they start coordinating with the Arnold-Chiari malformation, the Klippel file, and then scoliosis, especially when you see a rapid progression and a left scoliosis, because again, for some reason, right is what the body likes to do congenitally. And so when it starts being left, that risk just goes up. So always keeping those in the back of your mind. So a young kid, rapid progression left, absolutely needs further evaluation. Any questions about that? So this is one that's a kind of just a more sporadic one that they like to throw in. And again, this is where there's certain like key things that they'll ask on the test. And like, I don't think this is super database, but where knowing this helps, and then just kind of ruling it out. So these are one of those tough type questions. But a 6-year-old presents for left abnormality and also a history of skin disorder. So obviously they're telling you that for a reason. So can you connect the dots? So this is kind of Star Wars classic lumper or splitter, and then B and E are obviously splitting the two. E being the most common. So then E would be the first thing I want to say if this is typical eczema tibial torsion. But then when you look at the x-ray, this is not typically what you would see, right? So does anyone know what this classically goes with?
Blount's disease.
So Blount's is a good thought, because that should be, again, like if I hear a 6-year-old with leg abnormality, Blount's should be right up there. The skin disorder is where it gets weird, because those aren't really connected. So Blount's is more at the knee. And so that's why I kind of put that little rendition in there too, because you see that little guy's, it's actually bowing at his tibia. So not bow-leggedness at the knee, it's actually at the tibia. So Blount's would be, again, that's where it's not just some crazy diagnosis, and we'll come back to Blount's a little bit later, but that is something close, and like, you know, especially if you see a kid with that bowing, Blount should be there. But then this is actually of the bone itself. And this is actually a pseudoarthrosis, so you start getting where it looks like it's broken, right? And so it's actually where he has almost like a joint there in the middle of his tibia. And this is, and I guess I just threw in another, this is another test question where I saw the exact same thing. And so now you could narrow it down because there's only one choice that's the same. But this is another just like way that they showed it, that I found that they're talking about more congenital gigantism, progressive kyphos scoliosis. This one's no skin lesions or laxity, so they're trying to take you away a little bit. And this is where, again, it's kind of the classic for neurofibromatosis. So this is just one of those classic things that I remember being taught. And again, where pseudoarthrosis is a false joint, and it's just very common, where it's one of the most common causes. So if you ever see that, just think of neurofibromatosis. And obviously the test question could lead to it. And then part of it, I wanted to talk about neurofibromatosis because it does come along with short stature, scoliosis. So again, when you're seeing these type of congenital orthopedic issues, always try to think big picture, because this is where I've seen a kid like this get seen by multiple orthopedists, and it's our job as primary care docs to look big picture and say, well, this looks like you have neurofibromatosis, rather than just scoliosis. So this is one where you're seeing a kid that complaining of upper back pain. His mother reports that he's never been able to stand up straight on physical exam. Obviously doesn't look right, but you can see moderate thoracic kyphosis, increased lordosis, and a protuberant abdomen, just kind of meaning you got that curve now. So what's the most likely cause of this patient's finding? So this is that first, like, what is the diagnosis? And again, this is one of those that for some reason they always ask. I see so many questions about this because it's one of those, I think, that kind of sets people apart, and they want to make sure you actually know it, because like a lot of people look for scoliosis, but they don't always look for this. And it's just one of those easy like things to ask about. Does anyone know what this is? What would people guess on the test? No one wants to guess wrong. You're just going to skip the question on the test, or just close your eyes and hit a button.
I mean, maybe POTS.
So why do you think POTS?
Is that like the tuberculosis one that can go into the vertebrae?
Yeah. So it's a reasonable diagnosis, right? Like it has some thought. So then you would have to say, okay, that could cause the bones to be destroyed, and then you have some problems with the alignment. Then you would want them to give you something else to know about the tuberculosis, exactly like you said. So you kind of think through that, and like they gave me nothing about tuberculosis. So if they say he's from Mexico and his mom's coughing all day, then all of a sudden you're like, okay, well, why'd they tell me that? So this is not POTS. And then another way they actually ask it is they'll give you a similar thing with all these details, right? Trying to be like, what the heck? I don't even know anything about kyphosis. And they're giving me all these numbers and letters. And then they'll say the most appropriate management. And again, this is where it just boils down to, what does this patient have? What does that mean? And then they'll throw in again, does this connect with other things? And this is where kind of understanding, and this is Scheuermann's disease, or Scheuermann's kyphosis is, obviously they probably wouldn't put that on the test. But this is where they throw you off with the nomenclature sometimes, where I remember they put, instead of leg calf Perthes disease, they put Perthes disease. And it was like, my eyes just like would skip it, because you're looking for that leg calf Perthes. But Scheuermann's disease is basically gets into the congenital wedging, as we'll talk about. And then the answer on this one is just the exercising. But Scheuermann's disease is where you start getting those wedge in one way, and so then now you get the kyphosis, and then you have that wedge deformity. These often need surgery to really correct them. So someone as bad as that guy might, that the way he looks obviously would need surgery, much like scoliosis. But when you start off with it, and I've seen a few cases where it kind of comes up, and obviously this is one of those things that you're kind of screening as you're looking on physical exam on well child checks, because they don't always have significant back pain, but this is where the patient will come in and just be sitting like this, and you think he's just slouching, but he literally can't straighten all the way. So again, something to watch for. And puberty is again where that kind of progresses, and then you notice it a lot more. Definitely harder to find in people that are more overweight. And then I just throw in the pectus excavatum and pectus carinatum as two other chest wall deformities. So obviously, if you have a sunken chest, it can look similar, but differentiating those two, understanding the connection between these two. So again, scoliosis being something that connects Marfan's with the excavatum. The carinatum comes along with some other more unusual ones. Poland syndrome is the one where you're absent like the chest muscle. So these are, again, things to be watching for, but you can see that sometimes it's connecting the dots all over. I know at MUSC they have a clinic just for like repairs of these when they get to the extreme, but it's something that we watch. Just throw this in about in case you couldn't remember this one, it's one of those mucopolysaccharide, and then it does come along with some orthopedic issues like the knock-kneed, which we'll talk about. So obviously a more rare thing, but when you start connecting the dots, so you get all the different little things, this is when it adds up, and you have to start thinking in the genetic world, like we were saying. So this one is a 14-year-old who's otherwise normal white female, who presents for pain in the toes. He states that he sprains his ankle a lot, trouble keeping up with his friends and his activities, and he's had some bad posture per mom. So again, where that posture comes in is now you're thinking back stuff too, right? And so this is where you got to think of, again, the condition related to diseases with this is what you're all thinking. But then on the test question, they're just saying what test would most likely help you determine the underlying disorder. And so again, big picture, if you just looked at the picture of this kid's foot, does anyone know what you term this kid's foot? So you could like describe it to someone. So if you saw this patient and then you came out and talked to me about his foot, what would you say? I mean, again, thinking simplistic, describing it, and then there's obviously a medical term for what his foot is, and then that then would be what you'd have to go into your database or even Google to say, okay, since he has this, then what else can he have, and what else do I need to be looking for on my exam or asking about to make sure if I can connect these dots. So there's a couple things that you should describe on his foot. So does he have flat feet?
Is it like a hyper arch or something like that?
Yeah, so I mean that's the basic term. So yeah, he has a high arch. So does anyone know the medical term for that?
Archilus elevatus.
So what's the?
This is flat feet. It's the other one, the PES something else.
Yeah. So PES planus or PES cavus. So he has PES cavus, and then you'd say with his toes he has hammer toes. So that's why that's what he's complaining about, is that his toes get curled up and then they rub on the top. That knuckle on the top is actually rubbing on his shoes. So that's what he's complaining about, but it's all one big picture. Then you got to think, okay, does PES cavus, obviously like flat feet, right? You have flat feet, and then flat feet equals most of the time just congenital, like just normal flexible flat feet, right? But then you can have congenital problems with flat feet as being the tarsal coalitions, where you have a connection in those bones that's making your rigid flat foot. So in PES CAVUS, it can just be you have high arches, right? But then his is kind of extreme. And then when you start saying, well, he's having trouble keeping up with his friends, he has bad posture, you get into a little bit more systemic disease. And then this is where you're trying to connect the dots. So understanding the connection between those. And that's where, you know, this was rigid flat foot. You'd say, okay, I'll x-ray the foot to look for that connection. Now, PES CAVUS doesn't usually come with specific bony abnormalities. It's actually more a musculoskeletal or muscular neuro problem. So this is where you get into doing an EMG to look at the peripheral nerves to see if they're affected. Because this kid actually has Charcot-Marie-Tooth syndrome. And so PES CAVUS, you see the hammer toes to kind of correlate. You can do a thing where you step on a little block to kind of show how the ankle sits. If you're kind of really like, is this really arched high, or does it just look high because he's skinny? Those sort of things. So you can use something like that to kind of look at how the ankle is moving. But now once you have that, that's where you got it, you know, obviously idiopathic, but that's where cerebral palsy, tethered cord, muscle dystrophies come into play. And then Charcot-Marie-Tooth, Friedreich's ataxia is another one. And then Charcot-Marie-Tooth is that motor sensory neuropathy. So it's where the nerves are becoming weak over time. And so that's why he was spraining his ankle all the time, feeling tired over time. You get a stork leg deformity where the muscle is actually atrophying. But this is one of those diseases where this professional basketball player actually has Charcot-Marie-Tooth. So it's not something that's so debilitating that, you know, you're like, this basketball player could come in spraining his ankle all the time and have Charcot-Marie-Tooth. So that's where, again, getting that history, thinking through that. So you would ask those questions about nerve, looking at where he's losing some of that, the muscle mass because of the atrophy, because the nerve is starting to die. This one is more abnormality, like a more crazy one. So, but again, it's that connecting the dots. This is a 5-year-old that comes for a well child check, and then you notice he doesn't have fingernails or toenails. And then when you ask the mom, like, why didn't she say anything about her nose? She said, oh yeah, he gets those weird nails from his dad. So does anyone know what this patient has? And I'm showing you his knees too. So this one doesn't have a crazy name. It's a very easy name to remember. Can anyone think of the name? And what? And then think of a term that you use for the knee, and it's showing actually that he has lack of a bump, lack of a kneecap, and so it's a simple using the fact that there's an issue with the nails, and so it's called nail patella syndrome. So this is one too that again is orthopedic related with the no patella, the nails, and then this is where I think we actually had a patient like this where then someone just told him like, oh yeah, sorry, you just don't have good nails and no patella, but didn't think about, okay, is there any connection? And so this is where actually the lab test you'd want to do is a urine, because there is some kidney dysfunction with proteinuria that's related to this. So again, using these orthopedic findings to investigate more important things where you'd say, well, he came in for a well child check, whatever, he has nail patella syndrome, that's cool. But this is where checking that, because that could be, again, where you check it soon enough and then you can prevent problems. So this one is kind of going back to like little kids starting at looking at some of that stuff that we had talked about earlier. So this mother expresses concern that her daughter's hip at her 4-month well child track, she has trouble with her. The mom had trouble with hips. The patient was breech, but by 4 months, the only remaining physical finding of developmental dysplasia of the hip may be what? So an increase in hip abduction, persistent hip click, positive Barlow test, positive Galeazzi sign, or positive Ortolani test. So again, all of these you probably have heard of, but then now you're trying to think when it gets outside that normal like cookie cutter, kid comes in, you're doing all the tests. This is where you're trying to think, okay, now it's at 4 months, the mom hasn't maybe brought them in or asked anyone in, so there's that 4 months that has gone by, so you lose some of your ability to really check early on, and so then it's important to know what these are. Does anyone have any thoughts about this?
Hemonc is going with A.
Okay, so an increase in hip abduction. So that would be something that you would see if it was pretty extreme. And so and again, you can get into the nuances of like looking at it. So again, you're
We're
thinking,
kind of
well,
extreme in Hemonc.
yeah, and so it's one of those that like, and then you're thinking that because you're probably thinking, well, like the Barlow and Ortolani are the typical things that we do, right? And
And I
those,
thought that she might actually start to develop fibrosis around the capsule. And
Right.
so those
Right.
tests would be less likely to either dislocate or sublux. So
correct. So that's it,
yeah.
and that's exactly right. So like that's where those are the typical ones early on, just like you said, because there's the movement, and so those are off the board, and then the hip click, and so then it comes down to A or D, and then it's knowing what D is, right? Does anyone remember what the Galeazzi sign is? So it's not something that you can do just on little kids, but actually older kids too. So that's where you actually have them lay and then pull their leg up, and you see the difference in the height of the leg, and then you see on that rendition where it's because their hip isn't sitting just right, that one hip is going to sit off from the other, and so that's just one of those signs that you want to use more. And then that's, again, this is where this is a question that's trying to get into your whole thought process of that idea. And it does become hard because, again, if you kind of forget what that one is, then you start thinking just like you said, and ultimately it comes down to those two. But ultimately too, it's thinking through that again over time. The one thing is, this came out of a paper that was talking about all the stuff that we need to not do basically in orthopedics, and this was like not ordering a screening hip ultrasound to rule out hip dysplasia if you have no risk factors and clinically stable. So this is where people were getting into that, like, I'll get a hip ultrasound just in case, because they felt a little off. And so again, tying your physical exam, you're knowing what you're doing with risk reward type thing. And so what they're trying to say is make sure you do a good exam, make sure you take those risk factors, and then if you don't have any of those, then watching over time is actually the best thing, because there is false positive rates and then all that stuff. And so it's one of those that you would want to watch over time. Again, if you're not having the asymmetry like we were talking about, not limited motion, leg length discrepancy, hip click, the uneven folds, all those physical findings, and then the breach and other things like we talked about. So this is a 12-month-old who comes in for toe or in towing, and you think it may be from metatarsus adductus. Which of the following is the characteristic of metatarsus adductus? So again, if you see this patient and you come out and tell me it's metatarsus adductus, it has to be based on what finding. And so this is, again, one of those nuances where it's like, this question to me is kind of weird, because it's like, oh, who cares if I know what it is? But the whole point is, how do you know what it is? So this is where it gets into. And then I can also show you, I think the next one is about clubfoot. So obviously the differential in there, And so if you're saying, okay, is this metatarsus adductus and not clubfoot, right? Because that's the two branch points that you're usually doing. Now 12-month-olds is where you're getting out of the out of the clubfoot more into the in-toeing. So then you start saying, is this metatarsus adductus versus the other ones? And then, as we'll talk about, it's tibial torsion. So like, is it at the foot? Is it at the ankle? Is it at the tibia? Is it at the hip? And we'll go through those. So this one is one of those, again, making sure you know what metatarsus adductus is. So that is that classic where you, and this is like the physical exam you can do where you do a line through and you see one is going through the middle toe, and then one with the metatarsus adductus, it's going through the fourth toe because the forefoot is medial deviated. So it's where the actual foot is turned in, right? So it doesn't have to do with the hindfoot varus or equinus, because that's in clubfoot. And then this question is that, again, looking at that same idea, but now using, just like we were saying, best maneuver to differentiate metatarsus adductus from clubfoot. So this is where you start saying, okay, now on the exam, it looks like things are kind of twisted up and in. How do I tell the difference? So obviously it's not going to be tickle the lateral part of the foot, because that's just metatarsus adductus. Can he straighten it? And it's kind of, he's just curled in, right? It's nothing to worry about. It's not look for the crease, because again, that would be at the foot. And then you say compare the appearance of the feet. That's where, again, metatarsus adductus, it should be the actual foot. This is where we get into what actual clubfoot is, which is the congenital component of where it's down and twisted in, right? So that's where the equinus varus comes in, because it's actually tightening of the heel cord that pulls the foot down and in. And so that's where understand. And then there are other types of clubfoot. So you just have just down, just up, varus, valgus components. And obviously congenital clubfoot is the most common one that we see. So that's where, again, dorsiflexing the ankle to get it to see if it can actually go back is the way to know it's clubfoot. And then obviously it has a different treatment plan, and that's where we get into serial casting versus metatarsus adductus. A lot of times you can work on stretching and movement of their toes. So this is, again, another in-toeing one, but a 5-year-old. So again, always taking the age into account. There's no impact, so she's otherwise healthy. So now you just got in-toeing and a 5-year-old. So this is where the mom just comes in and is like, her feet don't look right. So this goes into that, what's the most likely cause. So they didn't give you the physical exam, so this is where you got to know the statistics of what's the most common cause in this patient for in-toeing. Is it femoral aneurysm, malignant malalignment syndrome, metatarsus adductus, clubfoot, or tibial torsion?
Hem-onc for tibial torsion.
And then what would be, like, why are you saying tibial torsion?
I'm trying to remember from one of my kids I had in chalk, but I think they tend to have a sitting position, like playing video games and things like that, and so they start flexing at the knee and curling the feet. So the
inward. W position. Yeah, so that would be, in real life, some of the questions you would want to ask. Then physical exam wise, which we'll go over, is where you could really tease it out. And so this is one of those tough questions because it is database, and tibial torsion would again be one of those okay answers, but actually the real answer is femoral aneurysm. So that's where the hips are actually turned in. And this is just age related stuff. So this is just once you get over 3, that becomes more likely, but not impossible. So this is where tibial torsion, if you said, I think it's that, then I would say why on physical exam, as we'll talk about. And that's where range of motion of the hips, just like you said, knowing the difference. And so that's where sometimes the database question is hard. And then obviously then we have rotation this way, and then we have bow-leggedness versus knock knees. As we'll talk a little bit about, this is one with bow legs. The mom's concerned that it's getting worse, and so she wants to get an x-ray. So then and this is where they kind of phrase it weird, and they'll say, what's the best support to get an x-ray? So what is here that like maybe the mom is just concerned, right? But then in your database, what makes you decide that you want to get an x-ray? And is it that a bow-legged appearance at birth, so the kid came out bow-legged? Well, no, that's not right, because he is, that's always true, right? A normal sequence of achieving motor milestones. So that's where, again, thinking through the what is the normal sequence, right? A symmetric appearance to the lower extremities. Well, no, that's where asymmetry would be what concerned you, right? So like where one is bow leg, like we talked about with that other one, where this why is one and not the other versus the natural progression. An absence of pain. Okay, well, that's not right, because it's when there is pain that gets you more concerned. And then the natural history of angle deformities in the lower extremity. So this is where this is where trying to think through, okay, what is there? And again, this is where I might have said it wrong. Like the normal sequence of achieving motor events is, again, one of those key things to think about. Did he not achieve the motor event? So if she's not walking by 3, then you're really worried. So this is where E is the answer, because you know that the natural history should be the bow-leggedness should have been going away in this 3-year-old kid. So this is one of those questions that, again, you kind of have to think through what they're asking you, and then make sure you read it in the negative or best thing, so ruling out things. And then those are always ones I like to read all of them, because sometimes one is like maybe, and then you realize there's one that is the center. Then this one, you're evaluating an 18-month-old who thinks the mom thinks he's pigeon-toed, so again, turned in. He begins to walk at 12 months, walks well. The intoing is noticeable. The range of motion at his hips, knees, and ankles are all normal, so you don't see anything going on there. And then which of the following is the most likely cause of this gait disturbance? And then now we got Blount's disease, like we talked about. So if you didn't know what that was, like you're trying to figure out, is that abnormal? But we know now that that's abnormal, so that's not a good answer. Femoral aversion, internal tibial torsion, metatarsus adductus, and then pes planus. So those are always going to be the lumped ones on these test questions, right? So that's where, again, using your thought process. Every once in a while, they'll try to trick you, and they'll throw in like lateral or like the opposite. So just make sure you read it good, because they'll throw in like external tibial torsion, and then you'll answer external tibial torsion for intoing, which is the exact opposite, wrong. So like make sure you read that and not just go with the, oh yeah, tibial torsion is probably the likely thing. But that's what you would think about on this kid, because again, that age, like we talked about. And then I think the last one is a 7-year-old that, again, intoing. This is where it's been going on. She sits in that W pattern. This is where you're like happy, because you're like, oh, I know this one. This is the hip. Well, they don't want you to say, this is not where they're going to ask you what the hip, femoral aversion is, where you're gonna have to know what's true about that condition, right? So this is where trying to think through that normal condition. So CT is not indicated. She's not at a high risk. It's not a big problem. She'll likely be able to participate. She should be wearing medial pads in her shoes to correct the intoing, and the intoing is likely due to a dietary deficiency. So this is a pretty easy one if you then can wrap your head around this is normal, and then understanding. So the answer on this one is C. And there's some data actually says like people that are really good, and like Marcus Lattimore had femoral aneurysm, and he was like, he would walk with like some intoing. So there's thoughts that he could actually cut and as a running back in football and do better, because he had a little bit of this. And this is a picture of the little girl sitting, and the one thing, like some people I've heard is like, I've talked to moms later, and the doctor was like, yeah, yell at her if she sits like that. And it's like, we don't want to make it an issue, and like we just want to say like, hey, try not to sit like that. And so it's not like they're gonna ruin their hip. It's just when they get into that always sitting in that it's just going to perpetuate it, right? And so it's just one of those where it's like habit wise. Crisscross applesauce is a better way to sit. So like my little girl will sit like that every once in a while. It's not like right when I see that I freak out and be like, oh my gosh, get up. So obviously your history of physical, important to know the parental concerns is I think one of the big ones, because I see sometimes people like wave off it. And I actually had a patient that I had seen multiple pediatric orthopedists that obviously know way more about this stuff than me. But the mom brought her in and was like, hey, well, can you take a look at the, I think the concern was abnormal walking. So I did all of these tests that we'll talk about. Had him run up and down, jump, do, everything, play games with him, everything, just to see anything. And I was like, Mom, I don't see anything wrong. And I was like, I'm sorry. I mean, I know everyone keeps telling you that. And she's like, no, I don't think anything's wrong. And I was like, what do you mean? Why'd you bring him to the third doctor to ask? She was like, no, my mom thinks something is wrong. I took him to 2 other doctors. They didn't even watch him walk. So how are they going to tell me he doesn't walk right or it's normal when all they did was an x-ray? And so like her concern was is no one was actually looking at it. So I think that's where knowing the parental concern and what you're trying to delineate and what they're worried about. Because if you just say, oh, that's normal, that's what this mom didn't want to hear. She wanted you to prove it wasn't normal, right? And x-rays didn't help with her because she didn't know what those meant. She just knew no one ever watched her kid walk, and her mom is asking her to bring her in to look at that. So again, gait is very important. Getting the maternal history, looking at the problems, and again, where it's coming about through the walking process, family history of abnormalities. That's where we start looking at signs and symptoms. So like, is it fatigue that's bringing it on? Looking at the neuromuscular component of things versus just an orthopedic when you're sitting. And then obviously the physical exam, looking at, always looking at the spine, looking for those tufts of hair, looking at leg length discrepancy, range of motion, flat feet. Because again, if your base is off, that's going to throw some things off. So some people come in for hip pain, but it's actually their foot that's flat that's causing it. Then doing the alignment component. So again, like we talked about with the metatarsus adductus one, having them lay down. So these pictures are them laying down and you're looking down as their feet are up in the air, and looking at the alignment component of that. So that's really isolating, right? Where the feet are. So they are actually in-toed there, or they out? And obviously that's where looking at comparing the two sides, knowing what's normal. Again, a little bit of out-toeing there is what's normal. Kind of knowing what range you have to work with. And I mean, I've never really officially measured people, really, except for like this little girl, where you're really trying to get it down to the T. But it's looking at all the different angles, then using the range of motion of the hips, again, them laying down with their feet up in the air, looking at the range of motion in the hips, making sure that they're symmetric and you can go in and out. And again, where femoral anteversion will have a limited motion, and it's limited in the normal, it's not actually limited motion, it's just shifted motion, right? So now instead of doing what it normally does, it now rotates a little bit different. And so comparing sides, obviously when you have one side that's the abnormal side. This is again from that paper of what not to do, trying not to do the wrong things. And then it says, do not order radiographs or advise for bracing or surgery for children less than 8-year-olds with simple in-toeing gait. So this is where I try to argue that you should never refer these patients to an orthopedic surgeon when the mom is just really concerned. Like, this is where you have to take a stand as a doctor and say, like, this is normal. And I personally know that there are sometimes that you're like, well, they just, and talking to my wife who does general peds, sometimes she's just like, well, they just want to talk to the specialist. And it's like, that's where you then say, okay, well, the specialist will say 2 options for this. It's either, because we had a kid like that was around 8, and I told the mom, I was like, well, 2 options are we watch it, or they cut her bone in half and twist it. And the mom like freaked out, like, why would you ever think we would want her bone cut? And I was like, well, that's the only other option. And so she just was worried she was missing out on like a good option. And then you get into the bracing, the little little nuanced things. And obviously that's when it is. And that they're not saying never refer these people. They're just saying 8 years old it's the typical progression, right? So this is where, again, going back to what in-toeing is, looking at metatarsus adductus, congenital, most common one. And you can see the range there. Knowing that this is where if it's rigid, you're casting bracing, right? But if it's very minor, the mom might be freaking out, but telling her about doing exercises, trying to push it. Shoes will help, it over time, but this is where we don't try to overdo it. Internal tibial torsion, again, where it's the most common in-toeing less than 3 years old. 90% resolved by 8 years old. Again, where we're watching for those very unusual things causing it. And then femoral aneurysm, again, greater than 3, usually slows by 8 to 10. And then that's where you can kind of watch it over time too. And then if you see that, again, super progression, the kid's tripping all the time, again, escalating is not wrong. It's just talking about trying not to go too far that way. And then surgeons like to do stuff because that's what they do. And then out-toeing is much less common. So again, flat feet, external tibial torsion, and then femoral retroversion are the names for the opposite. And then that's where we start getting into like femoral retroversion is uncommon. So then you start working that one, osteoarthrosis, stress fractures, skiffy, or things that you're like, since they're rotated so far at their hips, those are things I need to worry about. This is the progression that you'll see. So newborn, slight genu valgum, straight legs, 1 to 2, around 2.5, you start going knock-kneed and then straight. So this is that curve you would want to know. So again, on the test, that's where they'll ask you about those kids and they'll give you an age, and that's where knowing that the bow-leggedness should be gone by 3 because of the normal progression of things. And again, these have their own timing period. So thinking of when it's normal, when have we gone too far? And that's where at the bottom, it talks about no need for children less than 3. That's following a progression. That's where you can start measuring the difference in these legs. So you do bow-leggedness, like the distance in between. And then you can do in-toeing or genu valgum on measuring in between. So just kind of having that, so you're not like globally doing it, and that's where you can follow it, right? Like every 6 months, measuring those distances. If again, it's in all that normal pattern, normal stature, they're not super short, they don't have other issues, no lateral thrust. So that's where like the knee is shooting out. And that's where Blount's disease comes into play, because you get disruption of the normal cartilage. So things start coming outward. And that's when we start getting worried. So severe unilateral abnormal progression, persistence past 3, short stature, or lateral thrust is when you start thinking of, okay, what's going on? And then most of the time it's spontaneous resolution, and then occasionally those referrals. But again, that's where bracing, like I had to wear these weird boots that had a bar in between them to try to help some of my leg stuff, and they found that those are completely ineffective. So maybe my parents just didn't like me that much. But no, back then they thought that was like, hey, I'm doing what I can. So again, that's where trying to like make sure people know that, explaining that this is a normal process, it goes away, and we're watching for these things. And then saying that to the mom too, of like, hey, I did all these things and it's fine. So this is Blount's disease, like you guys were saying. It's an abnormality at the knee, and it's the x-rays and just severe form. And then knock-knees, again, the opposite, where it comes on 2 to 5. Then you got PES planus, external tibial torsion, causing it to be common. And this is again where we would watch. There's no need when this is going on. Some real bony kids, like you see it obviously a lot more. And then again, measuring distance greater than 8 centimeters in the intramalleolar. So like down at the bottom, if it's like super wide, then now you know it's very dramatic. That's when you, again, now that statistically that's an abnormality, and that's when x-rays and more investigation would be needed. And then just some differential and treatment thought processes of what that's causing. Again, delaying for a long time, where you're not really, surgery is reserved for greater than 10. Any questions about that?
Thank you, Dr. Holloway.
You're welcome. No questions? All right. Thank you, Whitney.